Hello, everybody. I'm so looking forward to co-chairing with Mitchell Warren of AVAC this 2021 R4P Journalist Fellows Program. And I'm very much looking forward to meeting each of you and hearing your views. Today, I'm going to talk to you about the evolution and current status of the global HIV epidemic. We're going to look at terminology and key concepts very briefly. We're going to look at the origin of the global epidemic and key scientific advances historically in HIV prevention and treatment. And we'll look at key indicators, regional epidemic diversity, and why tailored responses are needed to bend the epidemic's trajectory. So as a general rule, it's a good idea to put people first, and then the descriptor status or behavior, and to try to avoid abbreviations if you can. So use people living with HIV, men who have sex with men, people who inject drugs or people who use drugs, transgender people, transgender women, transgender men. Avoid military terminology wherever possible. So rather than targeting people, engage and mobilize them. Rather than targeting interventions, look at tailoring programs and approaches. And rather than a target population, think about priority populations. Other key concepts are eradication and elimination. So eradication is the complete and permanent worldwide reduction to zero new cases of an infectious disease, and no further control measures are required. Only smallpox has been eradicated. Elimination means reduction to zero, or a very low defined target rate of new cases of infectious disease in a defined geographical area as a result of deliberate efforts. It requires continued measures to prevent re-establishment of disease transmission. We're going to look quickly now at ending AIDS 90-90-90 and U equals U. I know many of you know these already, but this is just to make sure that we get onto the same page. So following achievement of the Millennium Development Goal to halt and reverse the HIV epidemic by 2015, the UN General Assembly included a target to end AIDS as a public health threat by 2030 among the 230 targets, and put in place a fast-track strategy to reach this target. So a 90% reduction in new infections and a 90% reductions in deaths by 2030. The fast-track targets for 2020 were 90-90-90 with respect to testing and treatment, fewer than 500,000 new infections among adults, and zero discrimination. Now, those ambitious 90-90-90 targets actually meant 73% of all people living with HIV having achieved viral suppression. And this is because the 90, the first one, means 90% of people living with HIV know their status, 90% of those who are diagnosed are actually on treatment, and 90% of those on treatment are actually virally suppressed. And we know that viral suppression protects people living with HIV from AIDS-related illness and greatly lowers the risk of transmitting to others. How have we done? Well, June 2020, there were 26 million people on HIV treatment worldwide, but the 90-90-90 goal was 30 million by 2020. So how does the HIV treatment cascade look in 2019? Well, as you can see, from 2015 to 2019, there have been big increases in testing and treatment. So we see that 81% of people knew their status, 82% of those who knew their status were on treatment, and 88% of those on treatment were virally suppressed. So this translated into 59% of all people living with HIV being virally suppressed. So it's below the 73%. It's certainly an increase, an important increase, but we have a ways to go. The new 2025 targets are seen as the 10s, the 95s, and the integration. So the 10s are the social and legal impediments to an enabling environment. So fewer than 10% of countries would have punitive laws and policies. Fewer than 10% of people would experience stigma and discrimination, and fewer than 10% of people would experience gender inequality and violence. In the center, you see 95%, all of the targets that we've just mentioned, plus 95% of women accessing HIV and sexual and reproductive health services, 95% of coverage for eliminating vertical transmission, and 95% using combination prevention, including the testing and the treatment and the viral suppression targets. Now, they integrate together on the right, with 90% of people living with HIV and people at risk being linked to people-centered and context-specific integrated services. And this places people living with HIV and communities at risk at the very center. So what would happen if we reach those 2025 targets? Here you see the projected impact on HIV infections, and you can see a great decline from 2019 down to 2025 if we reach those targets. The same kind of decline, perhaps a little less marked, for AIDS-related deaths, meeting those 2025 targets. And both of these graphs are by region, so you can see the impact by region. Now, about 10 years ago, we realized that there was a new paradigm. And that was because HPTN 052 was the study that found that in couples where the person living with HIV got early treatment, there was a 96% reduction in HIV transmission. So there was clear public health benefit to early treatment. And the START and Temprano studies showed that early treatment had an individual health benefit for the person living with HIV. And this led to the recommendation to begin treatment at any CD4 count. And also the campaign and the slogan, undetectable equals untransmittable. And so people living with HIV who take treatment as prescribed, they can achieve and maintain undetectable viral load and have effectively no risk of sexually transmitting the virus to an HIV negative partner. As you can appreciate, U equals U is a game changer, and it reduces stigma. So let's look at the origin of the global epidemic and some of the key scientific advances. So as we all know, the world was very slow to recognize the AIDS crisis, and you can see a number of magazine covers here emphasizing that. But when we look at the science, we see that there was direct evidence of extensive diversity of HIV in Kinshasa, in the Democratic Republic of Congo, by 1960. And so Michael Warraby did a fascinating study, and if you're interested in detective stories, this is a good article to read. And he showed, using a molecular clock analysis, genomic analysis, that HIV probably jumped species around 1900. And it was probably due, we think, to bushmeat butchering. And HIV took off due to colonialism that caused people to congregate in centers for economic reasons. So I recommend this article. We didn't recognize until 1981 that there was such a thing as human immunodeficiency virus, but we didn't even know for a while what was actually causing it. And you can see that as inexorably the numbers of people living with HIV increased worldwide, that there were many, many scientific breakthroughs. I won't detail them for you. You will hear much more during the conference, but we still need a vaccine and a cure. A go-to source for information is the AVAC website. I highly recommend it. Here is a chart on biomedical HIV prevention trials, the results and the milestones for vaginal rings, oral pre-exposure prophylaxis, for long-acting injectables, for monoclonal antibody studies, for preventive HIV vaccine, and for PrEP and vaccine. So in the time we have left, let's look at key indicators, regional epidemic diversity, and why tailored responses are needed to bend the epidemic's trajectory. I think you have these figures already. At the end of 2019, 38 million people globally were living with HIV. 1.7 million had become newly infected during the year. 690,000 people had died from AIDS-related illnesses. And it's estimated that since the start of the epidemic, 76 million people have become infected with HIV. 33 million people have died from AIDS-related illnesses. Now, here is a geographical presentation for the 20 million girls and women living with HIV. And you see in the dark green, Africa, Eastern and Southern Africa, is the most highly affected region, with South Africa the most affected country, followed by Uganda, Zambia, Mozambique, Kenya, Tanzania, Malawi, Zimbabwe, and even Ethiopia. In Asia and Pacific, India is in the lead with China, Indonesia, and Thailand. If you look at Eastern Europe and Central Asia, it's Russia and Ukraine. If you look at Latin America and the Caribbean, Brazil is ahead. For Western and Central Europe and North America, the US, as we know, is the most affected. And for the Western and Central African area, it's Nigeria, Democratic Republic of Congo, and Cameroon. Now, many trials, prevention trials, are taking place in Southern and Eastern Africa, and this is why. This shows HIV incidence among adolescent girls and young women 15 to 24 by color, and the darker the color, the higher the incidence rate. And incidence is estimated as new HIV infections per 1,000 person years at risk. Globally, if we look at new HIV infections by gender and key populations, we see that although they are a small proportion of the general population, key populations and their sexual partners accounted for more than 60% of new adult HIV infections globally in 2019. 8% were sex workers, 10% were people who inject drugs, 23% were gay men and other men who have sex with men, 2% were transgender people, and 19% were the clients of sex workers and the sex partners of all the key populations. It's important to compare the distribution of new HIV infections with that of the general population. And here we see for sub-Saharan Africa that even though males 25 to 49 make up 14% of the general population, they make up 23% of new HIV infections. For women, it's even more marked. Women 15 to 24 and 25 to 49 together make up 24% of the general population, and yet 49% of new HIV infections. The picture is quite different outside sub-Saharan Africa. So although males and females are 50-50 in the general population, among new HIV infections, men 25 to 49 constitute 48% of new HIV infections. In fact, overall males are responsible for 68% of new HIV infections. Now, if we look at the number of new HIV infections and AIDS-related deaths over the decade, we see that there have been reductions, 23% reduction in new HIV infections, 39% reduction in AIDS-related deaths since 2010. However, UNAIDS estimates that since 2015, the missed targets have resulted in 3.5 million more HIV infections and 820,000 more AIDS-related deaths than would have been the case had the targets been met. Now, COVID has had a lot of impacts. We all know that. And here is just some examples. These are the changes in the number of HIV tests and results returned by month compared to baseline in selected countries. 19 countries reported, and 16 of the 19 experienced sustained disruptions. And you can see Rwanda has gotten through unscathed so far. If we look at the change in the number of pregnant women receiving antiretroviral therapy during pregnancy per month compared to the baseline, we see 10 countries reported data and 6 of them experienced sustained disruptions, with again Rwanda being able to do reasonably well. If we look at the changes in the number of gay men and other men who have sex with men that were reached by HIV interventions during the previous month compared to baseline, we have 16 countries reporting, 4 of them with sustained disruptions. And you can see Kenya is the country that has been able to not experience disruptions. It's important because we hear R naught being used a lot for COVID to understand why we're not using it for HIV. I mean, we did in the past, but we don't now. So R naught is the number of secondary infections produced by a single infectious person in an otherwise susceptible population. If R naught is below 1, then the number of new infections declines and the disease disappears over the long run. If R naught is above 1, the number of infections rises and the disease continues to spread. Now for HIV, R naught doesn't really convey how HIV spreads through a population over a long period of time. It can differ by population density and social structure, and it may miss pockets of infections where the epidemic is increasing even as the overall trajectory appears to decline. So for HIV, you will hear people speak about the HIV incidence to prevalence ratio, and it's the ratio between the number of new HIV infections and the number of people living with HIV in a population. It combines 2 desirable conditions: long, healthy lives for people living with HIV and a reduction in new infections. So assuming an average life expectancy of 30 years after a person acquires HIV infection, and if there are fewer than 3 new HIV infections per 100 people living with HIV per year, the total population of people living with HIV will progressively decrease. So that's why the target is 3%, because that's a scenario where the AIDS epidemic gradually disappears. So globally, the incidence to prevalence ratio has fallen from 7% in 2010 to 4.4% in 2019. Eastern and Southern Africa has seen a decline from 7% to 3.5%. In Western and Central Europe and North America, it's now less than 3%. The Caribbean is not far behind at 3.9%. However, the remaining regions show little change since 2010. Other indicators you might want to track and look at if you're looking at specific countries is the association between HIV prevalence and income inequality. So income inequality is measured as the ratio of the average income of the richest 20% to the poorest 20%. And in sub-Saharan Africa, what we see is that for every 1 point increase in a country's income inequality, there is a 2% increase in HIV prevalence. Another indicator to track are the countries with discriminatory and punitive laws. And here we see in blue the reporting countries and in red the countries with punitive laws. Very striking, 129 of 149 countries criminalize any aspect of sex work, 111 out of 134 criminalize drug use or consumption and or possession of drugs for personal use. 92 out of 151 criminalize HIV transmission, non-disclosure, or exposure. And 69 out of 194 still criminalize same-sex sexual relations. Another indicator to look at are the countries with accountability mechanisms on discrimination and human rights violations in healthcare settings. Now, interestingly, national authorities and civil society agree on the reporting for complaints procedures, mechanisms of redress, procedures and systems to protect and respect patient privacy or confidentiality. However, there are differences in terms of the barriers to actually using these mechanisms. Barriers that are due to cost, lack of knowledge about the mechanisms, and lack of HIV sensitivity. Now, the gaps in HIV prevention are also being tracked. So you can see here in the center column the indicator. So we're talking about comprehensive programs for adolescent girls and young women, key populations who've reported receiving at least 2 prevention services in the past 3 months, condom distribution, voluntary medical male circumcision, and the number of people on pre-exposure prophylaxis. And finally, we track resource availability for HIV programs in low and middle income countries. And you can see there has been a plateauing, and we are short of the 2020 resource target, which was 26 billion. So we've tried to do a quick tour of these terminology and key concepts, the origin and the key scientific advances, and some key indicators regarding the epidemic. You're going to hear a lot more exciting scientific information as you go forward in the journalist program. Thank you very much for your attention.